when I submitted this case, I was still in U.S. So basically, this is a case I did in U.S. when in Cleveland Clinic, Ohio, where I used to work before. 59-year-old female, she presented on Friday evening because of an ongoing chest pain for 12 hours. She had an interesting past medical history of CABG, where she had an SVG to RCA because of an iatrogenic RCA dissection during a hard catheterization, which was actually reported to be normal 19 years ago. So she was in the 40s or late 30s when she had this procedure, a diagnostic hard cath that was complicated by a iatrogenic RCA dissection. She has diabetes, hypertension, and hyperlipidemia. Her blood work was okay, except for a troponin, which was trending up. That's her first EKG, which was relatively within normal limits, and repeat EKG showed T-wave inversion in the anterior leads. So we started here on medication for ACS, aspirin, atorvastatin, heparin drip, and nitroglycerin. We started with sublingual nitroglycerins, and we give her nitroglycerin drip, and in spite of that, she continues to have chest pain on and off. That's her echo. As you can see, she has apical akinesia, which might be an LAD territory or a tachycardia cardiomyopathy. So we decided to take her to the cath lab, and that's what we find basically. As you can see, the LAD is basically kind of subtotally occluded, 99% blocked, and she has very tortuous arteries. This is the caudal view, and that's the cranial view. Almost TIMI 0 to 1 flow in the LAD. That's her RCA. Interestingly enough, as I told you, she had an iatrogenic RCA dissection before her RCA was patent, and her vein graft to the RCA is patent. So at this point, anybody would interfere or not interfere on the LAD? Interfere? Okay. So I decided to interfere on the LAD given the fact that she's having an ongoing chest pain in spite of appropriate medical therapy. It was as you saw, it was very tortuous arteries. So we went with a soft wire, a microcatheter, and we put the microcatheter down into the LADs, and we switched it to a wiggle wire to give us some support. We couldn't deliver anything without an extension catheter, so we put a Guide-Zelda catheter and ballooned the lesion. After ballooning, there was some improvement in the LAD, so I have to deep throat the extension catheter to be able to deliver the stent. We delivered the stent here, and then that's what I usually do. I put the extension catheter into the stent to be able to deliver the balloon for post-dilatation, and that's what we did. And we have a good result there after stenting the LAD. And this is the image after we pulled the extension catheter out. So the whole LAD is dissected backwards. So now we don't have any flow in the LAD, and the LAD is dissected, and the diagonal is dissected. So immediately once you have that, you try to stop injecting and you try to use the IVUS catheter. So we wired the diagonal artery, we IVUS the LAD. For the sake of time, I think we have time to show the IVUS. The IVUS, of course, showed a really bad dissection into the LAD. Lucky enough, the dissection did not extend into the left main, it just stopped at the ostium of the LAD. So I went ahead and I stented the LAD. Post-dilated the LAD, basically. Then we had this area in between the two stents, the previous stent and the new stent, that didn't look good, so I IVUS'd it, and it showed an intramural hematoma. So we had two options: either you fenestrate it with a cutting balloon to fenestrate the intramural hematoma, or you stent it. So I decided to just stent it, to put a stent in between the two stents, and that's what we did. Well, I thought that the diagonal branch is a very good size artery. The diagonal branch is dissected. It's coming in between a stent. So I decided to stent the diagonal branch too. It was challenging to try to identify the ostium of the diagonal because at no view I was able to see the ostium. So, you know, like sometimes you have to have guts and believe in yourself, and you just stented where you believe that the ostium is. Then we did an IVUS again in both the diagonal and the LAD to make sure that the stent was not protruding badly in the LAD, which was not actually. And that's, we post-dilated. We did an IVUS, and the IVUS showed that the proximal end of the stent was underexpanded. So basically, that's what we ended with. So that is the final result. There's a big question now, retrospect, and I don't know if I should say that or not. We discussed that in the Cleveland Clinic M&M to know exactly what happened. And it was a split of 50-50. Some people thought that from the beginning that was a spontaneous coronary artery dissection that was supposed to be left alone. And some people believed that, and what happened 19 years ago when she had an iatrogenic RCA dissection was actually what we thought it was, also a spontaneous coronary artery dissection, and by mistake they tried to interfere on it, then didn't go well, then the patient ended up with a bypass, and that's why the RCA was still open, because the spontaneous coronary artery dissection healed by itself. That's a theory that it might go, given the patient age, the tortuosity that we see in the artery, which goes with SCAD a lot. But in the same time, the native RCA had atherosclerosis, which we usually don't see in people with spontaneous coronary artery dissection. These people usually have clean arteries. So was it really spontaneous coronary artery dissection that extended when we tried to interfere on it or not? The other thing is, even if it was a spontaneous coronary artery dissection, there is an indication to interfere on a spontaneous coronary artery dissection if the patient is having persistent chest pain, EKG changes, and no flow in the artery. And at this point, not every spontaneous coronary artery dissection is being treated conservatively. So it's allowed to interfere in this situation. So with this, I conclude. Thank you very much.